Exosomes are liquid. These are actually what's inside of the stem cell. So these are the growth factors. These are the worker bees, I call them. And they are essentially measured in the billions or trillions, depending on, what you're measuring. And they actually, the stuff that actually do the work. There's many different sources. You can get them from amniotic fluid, placental-based stem cells, and you can technically get them from your own blood, but they're not as strong.
Welcome back to the show, everybody. And today I have a special guest, Dr. Jesse Morse. He's a cutting-edge physician. He knows how to treat so many critical injuries that people are dealing with these days, always using the latest and greatest in the technologies that are available in medicine. So really excited to chat with him today. So Dr. Morse, welcome to the show, brother.
Thank you very much for having me.
So just before we get into it and I start asking you, all the different interventions that you're using, can you just give the audience a little bit of a background about yourself?
Sure. So I am double board certified in family and sports medicine. Back in 2020, I transitioned from your normal traditional medicine, sports medicine, to full-time regenerative medicine, quote unquote, stem cells. And then the other half of our practice is anti-aging, longevity, kind of a high-level functional medicine that kind of focuses on mitochondrial optimization, getting rid of a lot of toxins from the body and trying to optimize our health to allow our bodies to kind of heal itself.
Awesome. Yeah. Well, that's certainly what, a lot of people are looking forward to hearing about this on this podcast. I know a lot of people are certainly getting into, alternative health more and more just because, a lot of people are now saying that the, Western sort of medicine, has kind of failed them in many ways. And so, people are looking more and more into this. And so one thing that I want to chat with you about, right off the bat is Achilles tendon tears. You've talked about this a lot on your Twitter feed. And, it's something that I just dread all the time, having I, don't want to have that injury because I know how, devastating it can be. Before the show, we were talking about, Joe Rogan. I know that he doesn't have an Achilles tendon tear right now, but he did say that he tweaked it somehow. Chris Williamson, famous podcaster, he had a devastating one where he was, laid up, I think, for 6 to 12 months. As a Canadian, I always remember, when Golden State were playing Toronto and then Kevin Durant had that, brutal injury right away. He just grabbed his ankle. He was out for a full year. So this is, a very difficult injury to, recover from. So, as someone who, doesn't want to have that injury, is there something that we can do to prevent it?
Yeah, so the Achilles is vital to everything you do with your foot, unfortunately. It is essentially the same tissue from the calf to the Achilles to the bottom of the foot. So every time you fire your calf to walk, you need to pull on the Achilles to pick up the toes in order to not trip, essentially. So you can't not use it. The problem with the Achilles is that it has an awful blood supply in everyone. I don't care if you're 20 or 50. And you have beautiful blood supply right above the heel, you're going up towards the bone ends and maybe another half an inch or so. And then you have a beautiful blood supply coming down from the calf down to about maybe 3 or 4 inches above that other point. And then there's an area of about maybe 2 inches or so, maybe 3, that is called the watershed area that does not have blood flow. And this is basically what happens is you have this rope that starts to fray, and then eventually it either partially tears or tears in 2 pieces. As you mentioned, these are devastating injuries, absolutely awful injuries. And while a lot of people compare them to ACL tears in the knee, for the most part, ACL tears do well coming back. It's not a fun 6 to 12 months, and then people do fine in the long run. And 10 years later, they're still like, it was annoying, but I'm okay. Not the same with Achilles. Some people are never the same. They never get that mobility back. They never get that speed or push off back. And the rehab is just awful. Even my PT friends are like, it's the worst PT you can do. It's very frustrating. It's very painful and it's very debilitating. You can't do anything for 6 weeks before or after the surgery if you fully tear it. So ideally you want to prevent it. At the end of the day, this is one of those where you want to prevent. And if you start having discomfort in it, that's a warning sign. that you need to look into it further.
And so how can we prevent it?
Yeah. So ideally, you're being smart with stretching. You are being smart with your nutrition. You are. So I've seen a transition over the past couple of years, specifically in basketball, just because it applies to that the most. Where guys, when they were planting kind of on their midfoot previously, and their heel was kind of off the ground. But after that, most of the players and people in general have been putting their heel on the ground. So if you think about the energy transfer, when your foot is planted in midfoot, then you don't have any stress or very minimal stress on the Achilles. But when you have your foot completely planted, all of that energy is going through the Achilles. And a lot of times, if you tweak your calf, that is basically the precursor or the tissue right above it. And if that tissue can't handle the stress of what you're asking it to do, it will transfer that energy down to the Achilles, and that's oftentimes where it tears. If you start to feel something, look into it. Whether it's ultrasound, whether it's MRI, both are pretty sensitive. Ultrasound is actually even more sensitive if the sonographer knows what they're doing. Within 45 seconds, you can see tissue quality, severity of risk, any fluid changes, any partial tears. I mean, it's pretty obvious pretty quickly. MRI is a little bit more intense, a little bit more invasive per se, much more expensive usually, and it still works really well. And the tricky part is, now that you know that you have an issue, whether it's mild or moderate or pretty severe, then you can start to make an action plan about what you want to do. Therapy is usually vital. Sometimes injections, whether they're PRP or any of the stem cell lines, are going to be sometimes necessary because sometimes PT is just not enough. And ideally, you're trying to prevent surgery.
What if you don't have any kind of sign and you're just someone who just wants to prevent an Achilles tendon tear? Like, do you, for example, do you do, regular PT for your Achilles because you don't want to have this injury?
Good question. I mean, it's not necessarily something regularly you would do, but I think some of the different exercises you can be smart about, because unfortunately, this is a tendon that we use all day, every day. Similar to, say, the rotator cuff in the shoulder, anytime you pick something up, you're firing it. These have a tendency to wear and tear. Now, Achilles tears in women are super rare. Although I've seen a couple this year, fluky, but in general, they're really rare. There's a dichotomy of tears in ages for Achilles, usually for men in the early 20s or their mid 50s is usually where they have it. Although you can technically get it at any age. And you can get it, and now we're starting to see it rise more. I live in Miami. There's a lot of paddle here. There's a lot of pickleball and tennis, and people are very active. I've started to see a lot more in women because of the transition to women playing a lot more physical sports as opposed to, more gym stuff and stuff like that, or running or walking. Now women are starting to get a lot more active. And I think it's stressing their Achilles a lot more.
Are there any specific exercises that we should be avoiding in the gym completely because we don't want to have an Achilles tendon tear or to prevent one?
That's a good question. I mean, I think it's more so about being smart and understanding how much your body can handle and load, as opposed to trying to lift heavier than you should. That would probably be a better question for a physical therapist. There's not, the hard part is you want to be active, but you also want to make sure you're not doing yourself a disservice. So it's kind of a slippery slope. I don't think there's any one specific machine. Hey, don't do this machine or don't do that machine. I think it's a collection of wear and tear per se over the years. And 20 years ago or so, they would still do cortisone shots near the Achilles. We realize that's a big no-no. Even oral cortisone, oral prednisone, can add substantial issues with the Achilles. There's a classic antibiotic that happens a lot, fluoroquinolone is the class, that has a correlation, usually when done at the same time as prednisone, increased risk of rupture in the Achilles. And we've seen a huge spike over the past 6 to 8 years, especially in sports, obviously when you're going to hear about it the most. And part of it, I think, is the way these guys train, but also these guys are bigger, faster, stronger than they've ever been. And unfortunately, that tendon is the weak link.
Yeah. And I can see too how like maybe some other drugs like bempedoic acid, I think has been, weakly linked to increased tendon ruptures, not specifically in the Achilles, though, I don't believe. And then also too, like just with the use of anabolic steroids,
Oh
like
yeah.
people can lift more weight, but unfortunately, like their tendons haven't caught up. So you could see how
Yeah.
that could, influence them in sports overall. You mentioned nutrition earlier. So like, is this something that can help prevent an Achilles tendon tear? And like, what kind of nutrition should people be focused on in order to preventing the tear?
So in general, our ligaments and tendons are made up of collagen. Now, collagen is a little bit underappreciated. There's multiple different types. Usually, most people are taking types 1 and 3. You need vitamin C in order to activate collagen. So a lot of people don't get enough vitamin C. Only about 5% of humans make vitamin C in the body. Most of us are getting enough of it to not be deficient, but vitamin C is really important for many different things. It helps adrenal gland. It helps immune system significantly, but it also helps activate and work in conjunction with collagen. So a lot of people need to make sure that they're eating enough protein, which doesn't usually happen when most people are on the lower side. And in my opinion, I'm trying to lower the amount of inflammation in the body at all times. So I'm recommending eating clean. I'm recommending eating, avoiding seed oils if possible or as much as possible, because I definitely think there's a connection there, whether or not they want to admit it. I think American gluten is a huge problem. Dairy, to an extent, can be helpful, but also can be problematic with the way it's processed. So a lot of these things are really inflammatory. So unfortunately, you're just adding, unfortunately, more chaos to the body. I would say that's probably the foundation. And in going back to eating clean and whole foods,
What
as a
about regarding the collagen? Like, should it be more like the type 2? Because I'm hearing that type 2 is better overall for, tendons as opposed to 1 and 3
yeah, I
are
mean,
better
I try to
clean.
get everything. I try to get all the main three, but in general, I would say make sure you're eating, getting plenty of foods that have collagen in them, and I recommend to pretty much all my patients to take 10 to 15 grams of collagen a day. Because it's only going to help with your hair, your skin, your nails, and a bunch of other stuff in the body. Relatively inexpensive. Data on it is really good. Can even help with joint pain, with issues with arthritic pain, that type of stuff. So there's between collagen and creatine, I think they're relatively inexpensive, very safe, clean options that are just going to only help the body do what it's supposed to do.
And I want to talk to you a little bit about peptides later, but just specifically, on this conversation here, a lot of people are taking BPC 157, maybe for, an Achilles tendon tear, but most likely for, another injury, maybe for gut health or something else.
Yep.
For people who are taking it, maybe not continuously, but intermittently, would they have a lower chance of an Achilles tendon tear just because it may strengthen the Achilles tendon? Or is that something maybe that we can't say yet, but mechanistically it kind of makes sense?
I don't think we can prove that, but I think that's a fair statement. BPC is a fascinating peptide, naturally made in the stomach. The injectable form, which is the most common form, has about 10 to 12 different mechanisms, actually. I don't know how, but they've proven it. But the most common one is basically to heal ligaments and tendons and basically to help with pain and inflammation. So a lot of the times people will inject it in their quad or their butt or their belly. But a lot of my patients that come in that have Achilles injuries, that have calf injuries, you can have them inject it near the calf. Now, the oral one, unfortunately, only helps the gut. It's not much for the rest of the body. So if you're looking for healing, then the injectable form is by far the most effective. Unfortunately, it is banned in all professional organizations and for all athletes, Olympics, everything.
Yeah, there
Probably
was a
works, but
guy from what I understand anyway. I don't know how much you follow hockey, but Aaron Ekblad, the rumor is that's why he was suspended for 20 games last year. He plays on Florida. I don't know how much hockey you follow, but yeah, that was the rumor anyway. It was why he was suspended for 20 games, and he just even wasn't aware that it was on the water list. So that's what he said anyway. So.
I didn't know. I mean, I'm predominantly in NFL and baseball, although the Panthers aren't far from me. It's never been my personal niche, but it's unfortunate because these are natural in the body. Obviously, you're giving yourself a lot more, but they are super healers, and that's part of the reason why people use them. But unfortunately, the powers that be in the different organizations deem them to be too effective, and then as a result, they have very short half-lives. So some people, you can even have technically do them twice a day, but if they're testing for it and your levels are higher, they're gonna they're gonna pop you. And unfortunately, that's just the nature of the game that they play. They have to follow the rules, and although it is clean depending on sourcing, for certain people, they can't do it because of who pays them.
Yeah, that's unfortunate for sure. And definitely with you on that. I think they should be able to use something that heals them. It's been a few years since I've had anyone talk about stem cells on the show. I think the last time was Dr. Adil Khan, who came on, probably 2 or 3 years ago now. And so I imagine there's been some, advancements since then. But, who should consider stem cells in your opinion?
So this is a fascinating topic, and there's a common misconception. So I'll kind of clarify it. So what are stem cells? Most people think they go into your body and make all new tissue and all new stuff, but in actuality, they are a delivery mechanism of growth factors. I call them the ultimate traffic cop. Hey, you go over there and fix this. This is what you need to fix it. Hey, you go there, go here, go fix it. Now, there's different sources, different ways to get them. Traditionally, as an adult, you can get them from 2 sources from you. Bone marrow, usually out of your posterior hip, and fat. Actually, fat has beautiful stem cells in it. The difference between the two is the one out of the bone marrow ages as you age. And it has 2 types of bone marrow. It has the one that makes red blood cells and HSCs. Those aren't as potent per se or as helpful for injuries. And then they have MSCs or classic stem cells, or what we call mesenchymal stem cells, but really should be named medicinal signaling cells. But it's very small amount. The ones from your fat or from your adipose are actually really potent and very high in MSCs, but don't really have any HSCs. And the leaner a person is, the healthier their stem cells are. Their basically only role is to build fat. So if you're pretty lean, they've basically been chilling your whole life. Now, from a donor, then you have a couple more options. My favorite one is an amniotic tissue from the amniotic sac, actually. And while it's not true live stem cells, because you're not taking it out of that and using it immediately, the same process applies. These are the tissues that are usually used in Achilles repairs, or wrapping a tendon in an OR or a nerve or something along those lines. You can also use them in wound care. Those are usually written as sheets. These are the ones I use are actually micronized. So they're actually pieces so you can inject them.
And just explain maybe what amniotic cells mean, just for the people who don't.
So if you think of mom and baby, mom delivers baby, the placenta, and then the amniotic sac, which is basically housing baby and providing all this nutrition to build all the organs and everything, that they basically take that from a donated C-section. It's sent and checked for everything under the sun, almost like you're donating an organ. And then if it passes inspection and it's clean, it gets micronized into these small pieces or the sheets. And then it's either flash frozen or shelf life stable, depending on which one they choose. And then you can actually use that and buy it from basically a donor or a tissue bank. And then you basically use it to heal and to optimize. It's not meant to be done IV though. So these are super potent, very pure, pretty much as strong as you can get from a healing perspective, because the tissue actually works like a scaffolding. So your body goes in and kind of starts building on top of it. But it's using more the growth factors within the stem cells or within the different products, as opposed to classic stem cells. So if you were to strip the different types of stem cells of their name and you just look at them from different growth factor lines, you'll see have all these different ones. PRP has much lower ones from the blood, platelet-rich plasma. Then your bone marrow has a little bit different, and then it kind of so on and so forth. The ones coming out of you are very inflammatory. They create what I call chaos for a couple weeks, and then you start the healing cascade. But the ones coming out of a donor don't actually create any inflammation. It's kind of crazy, but they don't work that way. They basically just start healing. So they basically just go to the injury and they say, hey, this is injured, this is injured, this is injured. Here's what you need to fix it, go to work. And they basically just use these new materials to try to fix and optimize the tissue that is available. So when you're trying to fix, say, an Achilles for that matter, you have to inject it in the right plane, in the right location, ideally under ultrasound and in the specific areas of injury. If you're just injecting it in the hip or somewhere or IV, those cells some of them may get to the Achilles, but most of them are going to go other places because your body is going to be calling them for other things. So basically, if you want to fix a problem, you have to inject the problem. There's a couple other stem cell lines. Wharton's jelly, which is from the umbilical cord, is another common line. That one I have a little bit of issues with, secondary to the fact that most of the stem cells are very limited in that. Only about 5% of the umbilical cord actually has true stem cells. I promise you, they're not taking only 5% of it. And then you can get donor stem cells from a fat and from other things. And then the last line, which is technically in the stem cell family, is what we call exosomes. You may have heard of these before. Exosomes are liquid. These are actually what's inside of the stem cell. So these are the growth factors. These are the worker bees, I call them. And they are essentially measured in the billions or trillions, depending on what you're measuring. And they actually, the stuff that actually do the work. There's many different sources. You can get them from amniotic fluid, placental-based stem cells, and you can technically get them from your own blood, but they're not as strong. So you kind of have these different things. In terms of sizing, a stem cell, for the analogy, a stem cell is about the size of an American football stadium. An exosome would be a pea on the 50-yard line. So they're tiny, really, really tiny. And that's why there's billions of them in one stem cell. So basically the stem cell goes to the injury and it will release all these exosomes, or go to the blood-brain barrier and release the exosomes. And then the exosomes cross, because the MSCs are not allowed to cross. They're too big. So usually you have to basically do that, or you have to do like IV mannitol or something like that in order to open up the blood-brain barrier. The difference between America and in some of the foreign countries is a little bit different because we have different regulations than them.
Okay. And so thanks you so much. That was a really good explanation, that really clarifies a lot of things. But in terms of, the use of stem cells themselves, so I think that and correct me if I'm wrong, it's better for, say, like healing like tendons and tears and those kinds of things, as opposed to just like a general kind of like soft tissue injury, or someone who has like a herniated disc or something like that. Like, what would be the like best like uses of stem cells?
It's a good question. So, our clinic in Florida is a little bit different because we pretty much fix anything in the body. Not everybody does that, and everybody's comfortable injecting everywhere. I don't personally do spine. My partner does spine. You can inject along nerve roots. You can inject intradiscs. You can do epidurals with different types of stem cells. You can pretty much stick a needle anywhere. You can do hair, face, penis, vagina. You can literally put them anywhere. You have to be selective about your choicing because some are more inflammatory than others, as you can imagine. But the goal at the end of the day is to optimize the quality of the tissue. I usually tell my patients, I can't make your 65-year-old knee look like it was 18. That's not realistic. But I can optimize the tissue to the best of our ability with the resources we have. And as technology continues to expand, maybe we have better, stronger stuff in the future that can do even more than we can do now. Now, if you want a brand new structure, just go replace it. You'll probably be happier with it. But if you don't want to have surgery, or it's not an option for you, and you still want to have pain relief, get back to full function, better range of motion, less what I call fatigue, or be able to do things longer with the same body part, then stem cells might be an option for you. In terms of potency, this is a common discrepancy, so I'll clarify it here. If you think of a potency scale from 0 to 10, 0 being weak and none, 10 being the strongest stuff money can buy. PRP, or platelet-rich plasma, is about a 3, to give you an idea. 3.5 for some of the good kits, we call it. The stem cell lines, in my opinion, start at about a 6. So the bone marrow, depending on your age, a 70-year-old versus a 15-year-old, they're going to have completely different qualities of bone marrow. Adipose, probably maybe a 6.5 or a 7, depending on the quality of the person and their lifestyle. And then the stem cell lines not from you or from a donor, in my opinion, are probably 7, 8, 9, depending on sourcing and quality and a bunch of other factors. I'll leave 10 for possibilities for the future. But when people say, hey, can I just do PRP 3 times to get to a stem cell line? Sometimes you will make a stacking effect, but a lot of the times the growth factors just aren't high enough in that PRP to get to that same level of stem cells. It doesn't quite work that way. On average, stem cells are about 5 times stronger than PRP. And that's what I call a good PRP kit. So a lot of the times you have to understand the type of injury, the severity of the injury, the quality of the person that you are injecting it into. Is it an older person that just doesn't want to be in pain, or is it a professional athlete trying to play next week? Their bodies are asking different things. Then the question is, what tissue are you trying to fix? Are you fixing an area that has good blood flow? Or are you fixing an area that has awful blood flow? The meniscus, the ACL, the labrum in the shoulder or the hip. These areas are awful. They have very poor blood supply. You can't just use a PRP line. It's not going to be strong enough to fix the problem. And as a result, you are not going to be happy with the results. Taking it a step further, you have to break up the scar tissue, which is the body's way of trying to help, because that's going to prevent you from fully healing or healing to the best of your ability. So usually what I do is I do what we call needle tenotomy, which is basically numbing up the area, and then I break up the scar tissue, and then I'll inject whatever I'm injecting behind it. So you basically remove that scar tissue, and that cells will help with that as well. And then you kind of start and reinvigorate that area and say, hey, go to work. And then you guide them with good PT, good physical therapy, to say, hey, fix your compensation patterns, work on muscle balancing, and finally muscle strengthening. If you don't correct the reason why it happened in the first place, it's probably going to happen again.
Okay. And so for people listening, to break it down, like basically you're injecting growth factors that are going to enable people.
That's an easy way to put it. In my opinion, the term stem cell is generalized and easy to understand, but it's kind of a misnomer. Growth factors, in my opinion, are probably the best way to phrase it.
And that allows your body to basically heal naturally. And for some areas that have better blood flow, people who are younger, more compliant with physical therapy, they're going to have better success, say, over an area that has like poor blood flow, and maybe the person is just fairly sedentary, maybe they have other injuries, they can't do as much PT. So I imagine then you must have to have that conversation with some of your patients. Like you must feel more comfortable saying to someone who's like young and has like a rotator cuff tear, like maybe it's a small tear, not like a full thickness tear, that like this is probably going to work significantly better than, say, if someone had, like you mentioned, a labrum tear on the shoulder, is awful. And so you're probably going to get better results overall. Is that correct?
Yeah. The other thing that we've noticed that not many people do, even though I'm sports medicine trained through fellowship, I didn't even learn this way because it's not the norm. When people usually inject, it's usually through a cortisone mindset. Hey, put it in this area, and the cortisone is going to find it and calm it down. The problem is, I'll take the knee, for example. The knee has 2 main parts. You have the joint or the what I call the balloon, and then you have everything outside of the balloon. If you just inject stem cells or PRP or whatever into the balloon, it's not going to magically jump out and find all those other structures outside that balloon. You have to put the needle where the injury is. So the type of injection style I use is called prolotherapy, which basically means you're injecting each ligament and tendon at its weakest point, which is basically where it attaches to the bone. So for most people, when they do a knee injection, they'll do 1 or 2 injections. I do 12 to 15. Because the problem is, if you're just injecting one spot, you're hoping it gets everywhere, as opposed to watching it go under ultrasound and say, hey, here's your MCL going into your ACL, here's your patellar tendon, here's your quad tendon. So you're actually not only identifying the areas and breaking up the scar tissue, but then you're watching the product go into the tissue. The more injured tissue, the stronger the product you need, or the more product you need, one or the both. So a lot of my plans are custom. What I'm doing for you would be completely different than what I'm doing for an older person with a milder injury or worse injury, right? So it's not like one size fits all. And that's where a lot of people make the mistake. They're like, well, I got stem cells, it didn't work. Did they fix the problem? Did they use the right source? Did they put it in the right place? Did you have good physical therapy? There's a lot of levels to it, but unfortunately, the way people think about it, they just assume it's a one size fits all, and it's not. It's like anything in medicine. You have to personalize it, because there's different levels and different things. Each area may be a little bit more beat up in one person than the other. So maybe you put the stem cells in this part and you put PRP in the other parts that aren't that bad.
And in terms of, why people say would go to, say, a place like Mexico or Colombia to get stem cells, like, why do people do that when they have someone like you available in Miami?
Great question. So up until July, the patent 25, stem cells were illegal in America. Not illegal per se, but you could not advertise for them. In Florida, specifically in Florida, they passed a law in early July, that says you can advertise for them now. And there's certain guidelines and very specific parameters. Washington State, I believe, is the only other state that applies to that. But in general, all of the stem cell lines I mentioned are available in the United States, and we've been doing them for 10, 15 years. The only thing we can't do here is we can't take stem cells out of a person and multiply them and then put them back into you or put them into whoever.
But you feel, though, that you get better results taking it from the amniotic fluid as opposed to from someone else. So that's a
good question. They all work. The difference is potency, inflammation, volume, time to heal, and cost. Those are the parameters. So the issue I have, and the reason why a lot of people go to Colombia or the Caribbean or Costa Rica or Panama, or wherever, is that they can just take all these growth factors, all these stem cell lines, put them into an area, put a bunch IV, and never have a procedure from them, taking their stem cells. And it's significantly cheaper. The problem is you're assuming that they're clean. You're assuming that they're pure and there's no issues. And then the better question is, how many times are they multiplying that stem cell? It's a cell. Every time you multiply it, it gets weaker. After 7-ish rounds, I would not be surprised if the quality of the cell gets inferior. In my head, translation cancer, although I can't prove it. Good luck trying to prove it. The reason why we don't do, culture expanded MSCs here is because at the end of the day, it's probably not safe after a certain amount. And in those other countries, there's no big brother, FDA. They can do whatever they want, whenever they want. You're hoping that everything is pure and clean, but there's no one really checking them. We're just, kind of taking their blind word for it. And they don't have the medical malpractice that we have. So there's no one, hey, something happened. Sorry. You're in downtown Colombia and where some foreign country, and now you just kind of got to deal with it.
So it's basically a lie then that, you can get better stem cells, quote unquote, that's what people say are like real stem cells in those other countries. It's just that they have no FDA looking over them, so they can do, kind of whatever they want to some degree, but it's not like they're actually injecting like a better product overall.
Yes, in my opinion, yes. And from what I've heard, and I've talked to many patients that have had this done, their level of injector, usually physician, is subpar compared to many of us because they're trying to do it quickly. They're doing more of a steroid-based approach. Now, there's probably a couple exceptions to the rule, but in general, and that's part of the risk that people have to understand. And the other thing is they're really good at marketing, right? They're really good at like, hey, come here for a mini vacation. We'll give you IV stem cells. We'll put some in your knee and you'll be good. Maybe you're good, but maybe you're just band-aiding it. And if you do stem cells correctly the first time with the right volume, have the right injury with right rehab, you shouldn't have to do them again.
Okay.
You might have a spot treatment here and there, but in general, fix it right the first time. Measure twice, cut once.
Okay. Well, I definitely want to chat with you a little bit more about, Achilles tendon tears and stem cells today. But, I'm glad we had that discussion. You definitely cleared up a lot of things that, I had questions about. So, appreciate that. Lately, we've seen a lot of people on social media clean their blood. I think it was, what's his name? Paul Saladino, carnivore MD. He did it. And you've talked about various ways to clean toxins from your blood. So why is this so important?
So unfortunately, our environment is loaded with toxins now. And it's whether it's something that has been there for a while and we weren't privy to it, or it's just getting worse and now we're finally able to measure it and identify it. The level of microplastics, the level of all these crazy chemicals that are in our foods that we don't even know what they are. Many of the different things are what they call xenoestrogens, meaning your body sees them as foreign. And a lot of the times our body is having issues with it. A lot of the different things they do to gluten in the field, in the farms, to make the gluten last longer and allow that product to stay on your shelf longer and in your kitchen longer, unfortunately takes a beating on our inner body, right? It takes a beating for all of these things, and it creates a lot of gut issues, skin issues, and unfortunately with that, now we have to figure out how to get rid of all these things because they're aging us. They're causing a lot of problems. Whether it's microplastics, whether it's heavy metals, I see a lot of mercury. I see mold, mycotoxins is very common. You're having all these different pesticides and different things. So it's a little bit of a rabbit hole per se, but in my opinion, if you try to lower your toxic burden and boost your body's immune system, allowing it to heal itself, you're going to live a longer, healthier life. But unfortunately, all these, super processed foods and all this garbage just creates so much chaos in the body. It can't be surprising that it starts to break down.
And you've talked about various different ways of doing this, of cleaning your blood. Like some of them are, a little more practical than others. So, just kind of name off some of the practical ones first, which would be sauna, binders orally, which you can take, pre and probiotics, liver detoxification, such as through NAC or N-acetylcysteine, glutathione. And so is this something that you would then, suggest that everyone kind of get into the habit of doing before they would proceed to something, a little bit more drastic, like chelation therapy and that kind of thing?
Yeah. So, I think, from Northern Europe, there's a pretty classic study showing that sauna, or the ability to sweat, has massive benefits for the body. The skin is a massive organ. You're getting rid of a lot of toxins in your body. Obviously, you try to prevent them getting in there in the first place, but assuming you have them, that's just unfortunately the nature of the beast. Now you want to get them out, right? So sauna, taking a binder before, relatively semi-convenient depending on if you have access. Hot tubs versus hot bath, there's comparable results.
And what kind of binder are you talking about?
So there's a couple that I use. There's a bunch of different types. Pectisol is a very famous one, modified citrus pectin. GI Detox is another one that we use commonly. And unfortunately, binders aren't innocent. They can bind to natural stuff and healthy stuff. So sometimes you can lose some of the good stuff that you're not trying to lose, but it just comes along for the ride.
Like sodium and magnesium and that kind of thing.
Yeah, some of the normalcy, right? Your magnesium, but potassium. So ideally you're going to replace it. To make sure, in the morning, and probably do a binder at night or right before your sauna to kind of optimize that. And then, like, if you eat fish in the United States, specifically sushi, I promise you have mercury in your body, without a question in my mind. And it's accelerated over the past 5 years. The problem is the standard physician standard panel doesn't really check for it, because it's just checking, you're questioning your lab cores or whatever. It's just checking what's floating in your blood at that time. That's not a very sensitive marker, unless you just had a ton of it, this morning or yesterday or whatever. I actually do a provocation test where you collect first morning urine, you then come in, do an IV. It works like a magnet where it basically goes to bind all of, say, mercury and arsenic, which is DMPS. It basically binds that and it can't unbind. So you basically pee it out, and then you collect that for 6 hours and you compare morning to post. And that's an accumulation test, meaning how much is actually in your body.
So getting a blood test is not so accurate then if you're looking for...
Unfortunately not. There's some blood tests, mycotoxins is a really good blood test, but for heavy metals, in my opinion, this is the test. The best test is called Doctor's Data, pre and post, is the one we've been using for a long time. And that one actually measures accumulation. So the issue with mercury is that it's neurotoxic. I've seen significant correlations to HSCRP, which is an inflammatory marker for the heart. I've seen some people that have misperceptions of pain, which is kind of weird, but I've noticed that their pain scales are a little out of whack, messes with kidneys. So it's not really meant to be in our body. I have 25-year-olds that have 50 to 70 times normal mercury in their body at 25. And
that's from eating too much fish for the most part?
Nowadays, probably sushi, although if you have any metal fillings, that will play a role. And I wouldn't be surprised if it's in the water. The Florida Department of Health came out yesterday, or the day before, where they evaluated 24, I think it was, baby formulas, and 17 of them had significant levels of heavy metals in the baby formula. Arsenic, cadmium, lead, so that's even in a baby formula. So unfortunately, it's in many things. And, when a lot of these, they're measuring it at a low level, but if you're accumulating, if you're consuming that every day, there's going to be accumulation part of it. And if you can't get it out of your body, it's just going to continue to stack.
So,
So
what
that's the
is
tricky
like a
part.
safe amount of time, say, per week or per month, or maybe it's never, to consume, raw fish in general?
And that's the tricky part, because it's like, I don't think there's an easy way to determine if there is or how much mercury is in that fish, right? And it's like, oh, I went to a good restaurant, it must be clean. I don't think that's a safe argument. If it is an engineer that can come up with a device, almost like a toothpick, that measures how much mercury is in a piece of fish, you will make a lot of money, I promise you. But short of that, I don't know how you can measure it. So it's like, you just have to kind of pick your poison. You have to also understand which
Well, how often do you eat
fish.
sushi, or do you eat raw fish?
I don't eat fish at all. Never
You don't.
have.
You
But it's
don't.
more of a smell issue for me, not so
Okay.
much a flavor.
Okay.
I would if I liked it, but once a week, I'd probably avoid tuna and swordfish if you could. Those would seems to be the higher levels, but nowadays it's hard to say what is accumulating. But I wouldn't be surprised if it's in a lot of the waters. I've confirmed the water here in Miami, at least where I live, has very high levels of arsenic.
Okay. And, I know that I think I heard Andrew Huberman say that he had high levels of mercury and he started taking NAC and acetylcysteine. Is that something that you recommend for people, like, on a daily basis, or is it just like when they're consuming sushi, before or after? Or, if people are concerned about, getting their mercury levels down so they don't have access to some of the testing, but they, want to take a proactive approach, is NAC what you would recommend? And how often would you have them supplement with it?
Yeah, so NAC is a relatively inexpensive, for the most part, really safe supplement. NAC actually helps to heal the liver. It helps to detox the body and makes glutathione. When someone takes Tylenol, they actually inactivate NAC. So that's part of the when someone overdoses on Tylenol, they give them IV NAC, and usually you can save them. So basically, it works as a liver cleanse and as a detoxer, but indirectly, it also helps to anti-age you per se. There's some others. NAD works really well, whether it's NMN, NR, or it's sub-Q or IV. That's another kind of big trend that's going on right now. Some cool data in Alzheimer's. There's some cool trends in infertility. So we're starting to see a lot more shifts from NMN and NR, and the NAD is not really tolerated orally much, so you have to kind of do it as an injectable.
Yeah,
But
I was going to ask you about that, because you had a tweet fairly recently saying that basically everybody should be on some kind of NAD plus precursor. And so,
as we're starting to learn more about anti-aging, which is kind of one of my fascinations, we're starting to realize that there's a couple different things in the body that unfortunately plummet as we get older. Growth hormone, hormones in general, your sex hormones, your testosterone, estrogen, so on and so forth. And NAD is one of them. And unfortunately, NAD is a big detoxifier in your body. And when someone is in a drug and treatment alcohol facility, if they're, they have an addiction or whatever, a lot of the high-end ones will do IV NAD every day for a week. So they're detoxing their body. They're pulling out a lot of that and re-optimizing that mitochondria. So, you don't have to do it to that extreme, but an oral NMN or NR are on the cheaper side for the most part. And we're starting to see how important these are, because they all work in the mitochondrial level, which pretty much runs the show for the body.
and is there one that you would recommend over the other? I guess really I'm talking about NR or NMN. Like, do you think one is better more than the other?
I actually take both. I'm a little crazy though. I've taken NMN for years. There's only a little bit of data on them in terms of confirmed actual data for X product, and it's NR plus and it's Niagen. A little bit pricey, but the data is there to support it for them, which is probably justifying the price. In my opinion, most of them are probably comparable. Although a little hard to prove. And you can easily, I'd say 1,000 milligrams a day is a very common dose. 500 twice a day, you can get away with. It's very, very common, very clean.
Okay. Just want to switch gears a little bit now. You actually mentioned this a little bit earlier in the podcast because you've talked about this on your tweets. You're very much against American gluten. So what is the difference between American gluten and other gluten?
So the American gluten molecule has been modified probably 50 or 60 times, if I were to guess, between now and maybe 30, 40 years ago. If you compare the American gluten molecule to, say, something in Italy, it doesn't compare. A lot of the farmers, and indirectly, or maybe on purpose, are basically adding things, glyphosate, one of them, potassium bromate, another, different things that are impacting the quality of the gluten molecule, which is pretty much in every carb that you eat, be short of, fruit. And what's happening is these are leading to a lot of issues in the gut. And unfortunately, the gut runs the show for the body, right? There's a gut-brain connection, gut-skin connection. So what happens a lot of the times is I visualize the gut as almost like a sponge. And the sponge determines, hey, you can come in, you can't come in, you're not supposed to be here, you're a bacteria. But what happens is a lot of the times you have these different pesticides, different things that are basically poking holes in that sponge. So now things are crossing at will. And a lot of people describe that as gut dysbiosis or SIBO, S-I-B-O. So, in my opinion, it's a lot of it has to do with the foods and the garbage foods, I call it, that we eat. If you were just it's not gluten per se, it's unfortunately the American version of the gluten. So I went to Italy last year, you can buy Italian pasta at your regular, grocery store, and you're probably okay. It's the Americanized gluten that unfortunately causes a lot of problems. And that's where they feel inflamed, they get really full. It's an easy pivot to a different brand, and it might save you a lot of problems.
Okay. Well, thanks for clearing that up because I know that came up a few times on your Twitter feed. Let's just shift back a little bit to peptides, because I did want to get into this with you a little bit. So, a lot of people are aware now of BPC 157, TB 500. Those are kind of mainstream, the GLP-1s like Ozempic. But what do you think is the most underrated peptide that people aren't talking about?
Good question. Either MotC or GHK.
Okay. And so MotC, we know that can be good for insulin sensitivity, potentially increasing like exercise tolerance. And so from my understanding, people are using that more in cycles as daily use. Is that correct?
Yeah, usually I do it twice a week. I prescribe it twice a week. Usually done. So there's two mitochondrial optimizers for peptides. There's MotC and there's SS31. MotC is a skeletal muscle optimizer. It boosts metabolism and keeps indirectly keeping you lean. It also helps with mitochondrial support and functioning. And usually it's done Monday, Thursday, something like that. Some people will also.
Dose?
That's the quick tricky part. So there's about 3 different courses depending on what country you believe and what protocol you want to follow. There's a Ukrainian protocol. There's a Russian protocol. They most predominantly came out of Russia. And then there's what I call the American protocol. So the really aggressive will do a 10 milligrams, which is a whole bottle a week, which is a really crazy protocol. Then you can do a whole bottle every other week. So you're basically doing 5 milligrams a week or 2.5 milligrams per time. Or you could split the bottle for the whole month, where you basically do, twice a week, and basically split it up. When, the SS31 is comparable, but it predominantly does smooth muscle. So heart and, obviously the rest of the muscle. So I ideally try to avoid those on the same day. So I'll say I'll do those on Tuesday, Wednesday, and I'll do the MotC on Monday, Thursday to give you kind of a stack. Although it does get a little bit intense, and you could cycle on and off them as you wish. I like because they're working at the core of everything at the mitochondria.
Okay. And so from the patients that you've seen, the people that are using MotC, what have they noticed since they've been using it?
Usually they feel more energy. They have a better metabolism. They're indirectly going to probably lose weight just based on their metabolism. And it's overall just a sense of better well-being. It's kind of hard to describe, but I feel like that's a pretty common approach. It's not the cheapest peptide, unfortunately, especially if you get it from a reliable, legitimate source. So that's one of the rate limiting factors for it. But It's a cool peptide. It's probably not the first thing I would do unless you're trying to just be overall body optimization. If you're trying to heal, if you're trying to do other things, if you're trying to optimize your immune system, there's other ones I would choose ahead of that. But that's one of the ones I do like to add, or at least mention for what it does, and if they have the ability to afford it and want to consider it, then it's one of the ones that I think is not a bad idea.
And you think that using it twice a week, like fairly regularly, like maybe, 6 weeks on, 2 weeks off, something like that, is better, say, than some people are using it for like 10 to 14 days, like just for 2 to 3 months. And they're injecting like a crazy amount, like 10 milligrams a day.
So that's another protocol.
Yeah.
There's another one that I really like that I do twice a year that has a very similar protocol called Epitalon, which is a
Right.
brain one. So that, you can see it that way. You can do it that way. I like the more consistent approach, but, there's one protocol that says do a bottle a day or 10 milligrams a day for 2 weeks, which is an insane protocol.
That's,
But, so you
that's
can,
Epitalon?
Epitalon, but MotC has that, not quite the crazy, but similar approach. So like I said, some people can't handle that much. Like it's for some people, it's really potent.
Okay. They just find like maybe they get like too much energy. Is that right?
Yeah, they're
Or-
like too amped up. They're like, so,
Okay.
some people can tolerate a lot of them well, and some people can't handle them at all. So, and
Yeah.
a lot of that has to do with the different things going on in their body, and some of it may be sourcing and volume and whatnot as well.
Yeah, I mean, I certainly, want people to get, the best results they can possibly get. But just in general, I would prefer anyway to do something more consistently as opposed to, pulsed. But
Yeah.
that being
Yep.
said, if something is better pulsed, then, using it pulsed obviously is going to be the best solution. So
Yeah.
thanks for clearing that up. And then, you mentioned online, you're kind of open about, which ones that you take regularly. And so you mentioned, MotC and SS31. We talked about BPC 157, TB 500 or TB4. We know
Yep.
that can also be very synergistic with BPC 157
Yep.
for reducing inflammation and helping with injuries. Like, even just like right on the spot, meaning like
Very
people
much
who
so.
take it, like, they can feel better within a few days. It can certainly increase, flexibility and decrease inflammation and pain, which is, pretty incredible. But you did mention, a GHKCU as maybe the
Yep.
one of the more underrated ones. And so a lot of people are taking that for their skin health, but
Yep.
it's also good for joint health. So, why do you include that one in the ones that you take regularly?
So GHK is a copper-based peptide. It's a fascinating peptide. It's the only peptide that's not white. It's actually blue. And it has a cool little sneaky benefit. It helps activate stem cells in your body.
Awesome.
So there's a cool little benefit. They make it topically. They make it for the hair. They make it obviously injectable. There's probably an oral, but I don't know how effective it would be. And the cool thing now is they actually stack it with the BPC and the TB4. They call it GLOW, GLOW. The G is obviously the GHK. And then some people will add KPV, which is another anti-inflammatory, and they call that CLO with a K, obviously. So again, it just depends on how far down the rabbit hole you want to go and what you're trying to achieve. Some people really like it. Sometimes it burns a little bit. You just kind of get used to it for a minute or so. But in general, some people really like GHK, and it's a cool peptide. So that's part of the reason why I think it's helpful for, and I wouldn't be surprised if it has other cool benefits that we don't completely understand yet.
Okay. And then, you mentioned earlier in the podcast, as we age, unfortunately, some of our hormones, drop,
Oh yeah.
Growth hormone being one of them. So you mentioned, testosterone and ipamorelin, as something that you feel is beneficial enough to take. And so I imagine you're taking that because you believe that increasing growth hormone is going to have some beneficial effects overall. Is that correct?
Yeah, so unfortunately, growth hormone significantly declines with each decade, really starting in our 30s. And unfortunately, growth hormone is responsible for so many things in the body. Not only your muscle growth and maintain our normalcy of fat, but it also helps with healing. It's one of the big benefits of it. And if you're say you're 50 and you have 30-40% of what you had at 20, I mean, there's probably a correlation with issues there. So, depending on what you're trying to achieve, there's three main subtypes to make it easy: CJC ipamorelin, sermorelin, and then testosterone. CJC ipamorelin is kind of the notoriously famous one. The CJC helps with sleep. It is part of the growth hormone peptide family, and IPA is the same as Tessa-IPA. That some people are really sensitive to that, so they have to do a really baby dose, usually before bed. Sermorelin is more of an anti-ager one. It's not really considered a bulking agent, although it will keep you relatively lean and help you put on muscle mass. But it also is more of a maintenance. Tessa-IPA is considered the strongest one for shedding visceral fat and for putting on muscle. So it doesn't have quite the same potency for sleep. So there's each of them, and traditionally people do them 5 days a week, 30 minutes before bed on an empty stomach. 3 months on, minimum 1 month off is a standard classic protocol. You can check your IGF-1 levels. You can check other things if you'd like. If you have a history of cancer or active cancer, you have to be really careful with these, unfortunately. And then, as I said, sourcing. Right nowadays, you can get pretty much everything anywhere, but that doesn't necessarily mean they're clean and safe, right? So is it the peptide or is it the sourcing? Right. And that's the tricky part about it nowadays. There's not many places that you can get them from a prescription perspective that they'll actually compound it and make it for you. I happen to have one, but most of the people are not willing to go through that pathway because the price increases, as you could probably imagine. But in general, peptides are kind of the next wave, I would say, or of kind of personalized health. I've been using them personally since 2020, so I have pretty good exposure to them. And we continue to learn more and more about them.
And so there's just two more here on the list. And, I just figured, why not finish it off? So thymosin alpha-1, what would be the reason for taking that? And
so thymosin alpha-1 is a beautiful peptide. It's specifically for immune system. This was given to patients with HIV who didn't have an immune system. So the cool thing about it, it basically optimizes your CD4 to CD8 ratio, from my understanding of it. And it doesn't mess with your natural immune system. It just basically helps it. So a lot of my patients that have mold or autoimmune or just feel like they get sick all the time, you do it once or twice a week. There's a couple different protocols, and it basically just boosts your immune system.
Okay. And so it can help then potentially with people with autoimmune disease like
very much
hypothyroidism, eczema, stuff like that. And have you seen that in your practice where people have
I like it. Some people really feel like it helps significantly, and then some people are like, I can't really tell that it's helping, but based on the pathophys of it, and I have a feeling like it's definitely a relatively inexpensive and pretty safe and effective peptide that, at the end of the day, your immune system is pretty much all you have. Yeah. So if you can optimize it, the other one I use a lot for diseases and sickness is LL37, which basically works with vitamin D in the body to kind of address stuff. That one is more of a 1 or 2 month course as opposed to or indefinitely or long-term, a little bit different, but it helps with Lyme disease and mold and infections and that type of stuff.
Okay. And let's just, finish off the list. I know we only have a couple minutes left here, but 5-amino-1-MQ, what would be the reason for taking that?
So 5-amino is one of the few oral peptides that actually works. Most of the time, the gut beats them up really well. So this one actually tolerates the gut. This is technically in the growth hormone family, but it's oral and it's predominantly for cutting. So it's for weight loss. So if you don't want, to start a GLP, you don't want to do MotC, and you want something that can help indirectly, the growth hormone peptides can help as well. But if you want something oral, this is one it's not the cheapest peptide, but it's, for the most part, it's not awful. And it is oral, so you can't, and it will actually tolerate oral. So people do pretty well on it, and it's not like crazy strong. So some people, really won't have significant side effects. So that's one you can kind of go on and off depending on what you're trying to achieve and depending on, what's going on. But it's not as potent as the GLPs, right? So you have to understand potency in there. It may be complementing things as opposed to being the standalone primary.
Yeah. I mean, GLP-1s definitely have their place, and I've certainly seen some patients have incredible results with them. But, at the same time, it's not for everyone. Like, I don't see this too much in the research, but some people do experience a little bit of like anhedonia when they take it. They just
Oh yeah.
don't feel like the same pleasure even from, other things, just because, it may dampen down the dopamine system, completely. And then, some people just kind of don't want to have that significant effect on food overall. Food
Yeah.
is something that they enjoy. And then with the retatrutide, I've seen a lot of people now, say that it increases their heart rate and worsens their HRV like pretty consistently.
Yeah.
And so,
It's true.
it's good to have, other options out there, that can help with weight loss as opposed to just the GLP-1. So, I really appreciate you explaining that today.
Yeah, Reta is the future per se. There was a huge thing in the peptide, what I'll call community last week, 2 weeks ago. The lawyers that be sent a cease and desist to all manufacturers of Reta and all, probably a lot of the GLPs.
Oh, wow.
There's a new study that came out, I think it was 2 days ago, early studies of what the drug will be, Reta, whatever they name it. Long story short, the data is kind of silly. At 9 milligrams, which is a pretty big dose, it lost substantial weight. 25% of body fat of total, or actually body weight, sorry, excuse me, not body fat, body weight. And then something like 50% of the patients lost at least 30%, which is a ridiculous number. But it also did something fascinating and I'm glad they checked it. It actually impacted the WOMAC scores, which is a pain and arthritis scale. And there was a 70-ish% reduction, which is ridiculous. And it indirectly optimizes, I won't call it optimize, it affects the pleasure center in the brain, which is what you were alluding to in a second ago. All of them do. And that's where I've had a couple patients, not specifically Reta, but I've had a couple patients that were big smokers. They've always been smokers their whole life. They went from 3 packs a day to 3 packs a week on the GLPs.
Crazy.
So, they stopped it and they went back, they wanted to smoke again. So there's definitely a correlation there. Whether or not it's something you should be on long-term is a separate discussion. But in general, I think there's some really exciting things coming out. The difference, Ozempic or semaglutide we've been using for 20, 30 years in the peptide community. The difference is when Ozempic made it, basically ran it through trials and threw a carbon group on it and patented it, it's probably about 1,000 times stronger than what we have in our body. Of course, there's going to be side effects with it. That's a massive multiplier,
Right.
So you have to understand what they're doing and what some of the side effects are. And some people, they've done it once or twice and then they can't get rid of the side effects. They're there permanently.
Yeah.
And unfortunately, that's tough, especially a lot of women that use it for weight loss. Unfortunately, it starts to eat their muscle. And now they start to lose a lot of their stabilizers in their glutes and it increases their risk for hip fracture. So, it's a little bit of a double-edged sword. So you have to understand how to use them as opposed to just playing doctor and starting to inject yourself, because you might have some side effects that you didn't know were possible or don't know that are happening, and then maybe too late.
Yeah, for sure. If you're going to be, messing around with any of that stuff, you gotta weight train regularly and you gotta eat enough protein, because
100%.
If not, you're just going to be putting yourself at risk of, muscle wasting and muscle loss. And that just doesn't go for, GLP-1s. Anytime you're in a caloric deficit, you're at risk for muscle loss. So anytime you're, not eating very much and your calories are low, you're going to be at a loss. But I know our hour there is up and, you're a super busy guy, but, anything else that you'd like to mention, and can you, give people your Twitter handle, your clinic, and anything else that, may be coming up?
A couple things we didn't have a chance to cover, but I'll summarize in about 30 seconds. Filtering also includes the blood toxins, also includes something called EBOO, which is basically blood cleaning from an ozone, which is a modified form of oxygen. That does microplastics. We've confirmed that does pretty much kills any toxin in the body or in the blood. It also will pull out blood clots. It pull out a fair amount of those. The next level above that would be TPE, or a therapeutic plasma exchange, which is another level, basically pulling out and swapping out 20% of your plasma, which is basically where a majority of the toxins stay, and then swapping it from a donor plasma. And then not available in the United States right now, the one you alluded to for Paul, is what we call enuspheresis, which basically hyperfilters your plasma, no donor, and basically does it twice over the course of a couple hours and removes early data 70%, somewhere around 70% of microplastics in the plasma
Wow.
were removed. Although that's not FDA approved, I think it's probably going to be 27 if I were to guess. So you have to fly to Europe or Spain or some other parts of the world, from my understanding, in order to get it. And these aren't cheap, 5K, 7, 10K. So they're not cheap. And a lot of the times you have to do them multiple times,
Yeah.
so I'll finish that. And people want to contact me. The Osteopathic Center in Miami is my main office, but we have 4. And then my primary thing I use for social media is Twitter, although I am on the other platforms. Instagram, LinkedIn, so on and so forth. And then if you have any questions or anything, I'm happy to help as much as I can as we continue to educate the world about the different things available. And there's some really cool, exciting things that I know about that we can't share yet that are coming.
Well, Jesse, man, it was awesome talking to you today. You cleared up a lot of the questions that I had. I didn't get through everything, unfortunately. So maybe in the future we'll have to do, a round 2. And ironically, some of the things that you mentioned, like the EBOO and the TPE, those were some things I actually wanted to get to today. But so I'm glad you did briefly touch on them. But thanks so much again for coming on. I really do appreciate that. And thanks so much, everyone, for watching. And as always, I'll be back with another episode soon.
Thank you very much.